Hello, students. This is the OQE questions for Chapter 7. And so I've divided them into categories. The first is general, and then sexual, affectional orientation, and then gender to make it a little bit easier. And so the first category is general. The first question is, are LGBTQ plus members more willing to speak to therapy or to seek therapy? Are they more receptive to therapy? And would they feel more comfortable with a hetero-identifying counselor or a counselor from the community? And so in my experience, individuals in the LGBTQ plus population are open to counseling just as much as their hetero cis counterparts. I don't believe that it's more or less so than the general population, since there are so many factors that impact this. Individuals who, are kind of pulled away from the therapy community for different reasons or pulled towards it. Many individuals do seek out a counselor who is in the community as well. That's not a requirement for all individuals. I think what's important is that the person is competent and affirming to the community. And I think that that does a lot more than just specifically the identity of the counselor. Especially if the concerns are not specifically related to their gender or affectional or sexual identity. There may be a little bit less of this, focus on how does my counselor identify. I think that if counselors present themselves in an affirming manner and truly do the work to understand terminology, understand the common issues, and just be open and welcoming, I think that individuals in the community are more likely to feel comfortable with them. How accepting is the community when it comes to suggesting therapy to them? It's highly dependent. If a therapist suggests an individual in the community should be in counseling simply because they're in the community, that probably won't be received well. That's like taking any identity and saying because you have that identity means that you definitely need counseling. But if the suggestion for counseling is due to helping the individual cope with things that they're legitimately going through or circumstances or struggles that they have, then they're more likely to be open to the suggestion just in the same way as their hetero and cis counterparts. How effective can a hetero or cis counselor be at establishing visibility for the transgender or the LGBTQ plus population? Counselors can be extremely effective in working to advocate for this community, especially because many of us may be in a more privileged position to have some kind of platform or opportunity to be an advocate. And so, obviously counselors are educated, right? We have master's degrees or higher. We have experience. We have people listening to us. We have platforms. We might have money, not always the case, but we have some privileges that we can definitely use to be advocates. But so we as counselors, or perhaps as humans, should use those privileged identities in whatever situations they may be to advocate for anyone in marginalized populations. So that's something that's pretty important overall. While working with LGBTQ clients of various age groups, counselors consider developmental factors in treatment. What are some appropriate ways to address sexual terminology, to simple concepts of gender and nonconformity to children? And so what I believe is that some of these concepts should be incorporated just like anything else from a very young age. And so as you're teaching, even an infant, a newborn, a young toddler, whatever, language and understanding of the world, these should just be incorporated into that. When people talk about, how young is too young to have the sex talk with kids, I say, well, really, that should have started at a very young age, just telling them appropriate names for parts, helping them to understand consent, and, being able to give consent or to receive consent, things like that. And so this is sort of similar. And so it's important for counselors, us as counselors, to use open and affirming language without prejudging. This would be important in any situation with clients. We should not make assumptions on how clients identify, how the individuals in the world identify, and so on. It's important to work from the client's developmental level as well, obviously. Next question incorporates a couple of people's questions. What are some effective and proven ways beyond individual and group counseling interventions in which counselors can advocate for the LGBTQ plus community as a whole? So there are a number of ways that we can be advocates to different communities and not just this one. But there's advocacy at the individual level where you're advocating for a specific client who came to see you or individuals in your life and you're specifically helping them. There's also advocacy within the political world where you advocate against or for bills that would help or benefit a community and advocating against ones that harm communities. There's also advocacy where you might speak out for the community in your day-to-day life and make others aware of challenges they face. So just being knowledgeable of it and spreading that information to others is really important. Finally, you can work to be knowledgeable and use appropriate language and be affirming to the community, and so kind of modeling that behavior as well. There are probably lots of other ways to be good advocates that I've missed, but those are sort of the ones that come to me immediately. Next question is, what recommendations do you have for supplemental information regarding the community? If you don't feel confident or things like that. First is to explore your own beliefs and identify your own personal biases, because these will be important to be aware of and potentially challenging them as you move forward and work with clients. You should educate yourself as much as you can. And so looking at some great online resources, there's lots that are mentioned in your textbook, but some of the ones that are my go-tos are it's pronounced metrosexual.com and lgbtscience.org, but there's tons and tons of other ones. There are also many trainings you can engage in, some free or low cost. And so locally, the Florida Counseling Association has several divisions that offer webinars free for members or low cost for non-members throughout the year. In addition, Algebatic, which is mentioned in your book, that division of ACA offers monthly webinars currently that are at a low cost. And so there are lots of different topics. And once you begin to feel a level of comfort, you can start to work with individuals in the community, get to know them. You can co-facilitate groups or sessions with a colleague to help build your competency and your efficacy, and move on from there. Next, we have sexuality and affectional orientation. Fixing it on the printout. So the first question under this area is, I think the textbook mentions that if a client asks for reparative therapy, the counselor must refer the client to an appropriate counselor. Is that biased? Could that be considered biased? The counselor could be an atheist and doesn't want to work with the client. Is the referral reason because the ACA does not approve of it, meaning you would refer not based on your values, but ACA codes, correct? So ACA codes tell us that we do not engage in reparative therapy. It is not okay. It is harmful to clients, and we cannot engage in it. And also our state licensing boards in many cases as well kind of follow that. And so these are things that we cannot do as licensed professional counselors. So it's not about our individual belief system. So even if we have, very conservative religious beliefs that maybe believe in that, that's not something that we can practice. So ACA is the governing body over all counselors. ACA has been very clear in their stance against reparative therapies. As counselors, we believe it's unethical to engage in such practices. And so if a client feels that this is what they're looking for, we must be able to explain that counselors do not perform this type of counseling, explain to them, why we don't. But if they insist on seeking this kind of counseling, we would refer them to individuals who might seek it, who most likely are not licensed, in some cases aren't even trained as counselors. In the end, it is their decision on what they want to do. In some locations, reparative therapies with minors are illegal, and so it can't be practiced anyway with anybody under the age of 18. And so here in Florida, I know Alachua County, it's illegal. I don't know where else offhand, but again, that's only for minors. And then there are some states around the country that have it illegal for minors as well. So it's important to be aware of the legalities where you're practicing too. Next is, if omnisexual and pansexual individuals are attracted to people regardless of gender, how is this different than bisexuality? And so when we look at the word bisexual, it includes that the bi, right? And bi assumes a binary, meaning two, right? So for a gender binary to exist, there are two genders, male and female. And so being bisexual is that there are these two genders and I'm attracted to both of them. So that kind of practices that dichotomy. Whereas omnisexual and pansexual do not assume the gender binary, you're either male or female. It recognizes that gender is fluid and that there are not only two defined gender options, that you could be gender fluid or two-spirit or gender queer or gender non-conforming or whatever. There's all these different ways that gender can express itself, and so they're just more inclusive terms. What is the cause of asexuality? Are there common patterns found among these individuals? Is there a cause for being asexual, and how do you differentiate between someone who's asexual and someone who may not be interested in sexual activity or sexual relationships due to repressed memories and trauma? And so there are no causes of asexuality. Similarly, in the way that there are no causes for homosexuality and bisexuality. Asexuality, by definition, is a lack of sexual interest with other individuals. It's typically when there's no sexual attraction present, like I don't find myself sexually attracted or like romantically attracted to another person, or affectionately, I should say. So that can be differentiated between an individual who may abstain from sex or be turned off by sexual activities due to trauma or other physiological issues that may be present. So they may have that initial sexual attraction or affectional attraction, but then they get turned off by the idea of engaging in the behaviors with someone else, or they don't seek them out because of that. Or there could be pain disorders, such as like vaginismus or even erectile dysfunction and things like that just prevent someone from engaging with another person because of those issues. So you can explore the person's sexuality, their history, the ways that they think about sexual behaviors and so on to determine or help them to determine which of these categories they sort of fall into. But it also depends on how much distress that causes the client, because if they're okay with not engaging in sexual activity with other people, they feel like they don't need to have affectional relationships. They don't feel like they want to engage in romantic relationships, not out of fear or anything. They just feel comfortable being who they are and the way they are, and they're okay with their life, then, do we need to change it? Does the client want to change it? And so that's important to look at as well. What is the best way to support a client's coming out process and unsupportive family and friends? What is some advice to give a young client who plans to come out but knows their family will be against it? What are some suggestions we could give to them, assuming they're too young to move out or be on their own? So one of the biggest issues with the coming out process can be safety and security. And so especially if the client is a minor or they're receiving some type of support from family, like financial, or they're living in the house or whatever, it may be a safety and security issue for them to come out. And so you may have to spend a lot of time working with that client to build peer support, support networks outside of their family, other adults and mentors who could be emotionally supportive to them, even help them identify plans of action if they do come out or their parents find out and they're kicked out of the house, or their emotional or their financial support is cut off. And so a lot of planning with them, a lot of exploring options, a lot of just helping them to kind of sort out these issues. And, it may take a long time. They may not come up with a concrete plan. They may decide to put off coming out for quite some time to their family because of these issues. Sometimes it's helpful for them to come out to other individuals in their life that will be supportive at first, so that they know that they have some backing before they come out to those other, close family members and stuff like that they're unsure of. It may even be the decision never to come out to family or postpone it until they're more self-sufficient. In many cases, our job is simply to be a sounding board and a safe place for clients to have these conversations. Are sexual scripts only the internal messages society defines as normal, or does it take into account what we as individuals think is normal? So sexual scripts, from what my understanding is that they're personal to each individual, and that in some ways they're created based on what we're taught, by parents or teachers or media or peers or the norms of society as we develop and grow. But in other ways, it can also come from our own beliefs in what is right or wrong, those things that we start to develop as we get older. Also, what experiences have we had, or things we're interested in? What do we enjoy or not enjoy, or what do we find ourselves pulled to engage in or not engage in? And so it is very individual, which could be based upon, again, you look at social learning theory and things like that, could be based upon some of these external things also. In the book, on page 208, the author says cognitive interventions can be used to help clients challenge traditional sexual scripts. Does this mean like using CBT techniques? It is possible that cognitive behavioral techniques can be used as well. Cognitive strategies are often lumped into CBT, but they are a bit different in that they specifically emphasize rationality, thinking processes, meaning, and understanding. So they're used to increase freedom and control. They're used for decision making and problem solving. And so cognitive strategies, an example is like if you're working with a client to help them discern their future career goals or career options or college choices, that would be a little bit more cognitive than cognitive behavioral, because it doesn't really have that behavioral piece, those behavioral changes that need to be made. And so in many cases, CBT could be used, but in this case, they're specifically talking about cognitive strategies that focus on that thinking and perception. Next question is numbered incorrectly, so that's why I got a little confused here. Pretty ignorant question coming up. I imagine a woman that's in a lesbian relationship dealing with domestic abuse would be suggested the same services as a heterosexual woman. But are there services for a man in a gay relationship dealing with domestic abuse? To complicate matters, what about a gay man and a child who is seeking protective services from their abusive spouse? I don't mean to dismiss the reality of heterosexual men dealing with domestic abuse by omitting them from the question, just wanted to focus on this minority community. And then someone else asked the question, do sexual assault programs exist for men? I've heard of many for women where the address may not even be disclosed for safety purposes, but I don't think I've ever heard of one for men. So this is a huge, huge issue that we realistically face, is that there are not shelters for men. They're not common, I guess I should say, because there are some. They're just very few and far between and very hard to find. An additional issue is with the transgender community, because there are a lot of situations where there's violence, domestic violence, specifically perpetrated on transgender women. And these women are often denied spaces in women's shelters because the shelters feel like they are not women and they don't deserve a place there, or they feel like, somehow there's going to be some kind of issue with this. And so those women end up having an immensely, incredibly difficult time finding safe places to go. And so, again, there are some shelters that have been created for the sole purpose of individuals in the trans community who, cannot find shelter elsewhere. And again, it is a huge issue in this community, and that's why it's so important to talk about. And so what ends up happening is these individuals who can't find shelters end up going back into those dangerous situations. They end up going back with their perpetrators, and, the violence often gets worse and causes many issues. And so it's a very, very dangerous and sad circumstances. And so there are some agencies, again, kind of working on expanding this, but there are few and far between. And so this is definitely something that if you want to get involved in advocacy work, this is a huge, huge area of need. In the text, it says that coming out too early can create great distress for a client. As a therapist, is there a guideline in regard to the proper time to support clients in coming out, or is it more situational? And so this is very, very situational. As a counselor, it's not really for us to determine a time frame. It's about how comfortable and prepared the client is in making that decision. And so it could be a relatively quick process. Perhaps the client has already done a lot of work on their own, and is just coming to you for like that last bit of like, okay, okay, I'm ready to do this. And others have a long way to go. They're very early in their process, and there are a lot of complicating factors maybe in their world. And so there could also be a lot of work for the client in dealing with this in counseling, or very few. And so again, it's very situational. I've often wondered if people who are bisexual and commit to sharing a relationship with a person of the opposite sex have an unmet need as a result and miss having sexual activities with individuals of their own sex. And so kind of going back to the idea of switching terminology from sexual orientation to affectional orientation, I think that's really important in this situation, because when you think about a bisexual person and you hear that word sexual, you think about sexual organs and sexual behaviors and sexual acts. And so, if sexually someone is attracted to the male body and the female body, if I'm in a relationship with one of those individuals and engaging in sexual activity with one of those those sexual bodies, then am I missing out on what could be with someone in another sexual body? Whereas when we look at affectional orientation, it's, finding someone that you feel a level of connection with and comfort and enjoyment, and sex, can be a part of it, may not be. And so by that rationale, I'm with a person who's fulfilling me in those affectional and relationship ways that I need to be fulfilled. And so part of that may be my sex life. Is it, maybe going to make me miss that sexual organ and things that are done with that sexual organ? Possibly. But when you look at it realistically, it's not just about the sex and the sex organs. It's about so much more than that. I'm trying to make sure that I covered everything that I wrote. So sexual satisfaction may not be tied directly to the partner's specific genitalia, but the sexual acts with which they engage in, and those can be similar. Depending on who you're dating, you can engage in a lot of the same behaviors with and without the aid of toys and other devices that can be implemented. How can one prevent countertransference when working with a client that is experiencing sexual orientation issues that a former partner of one experienced and which caused great emotional pain to oneself? So I'm not sure exactly what this question is asking, but transference is part of the counseling that happens. It should be monitored and addressed, sometimes directly with the client, sometimes indirectly, or the client or the counselor can just be aware of it. So we should be out on the lookout for that, as well as any countertransference issues. So things that are happening with the client that are triggering us. And I think that that's what this question is getting at, that, if we encounter a client that is experiencing issues that, like, I'm the counselor, my former partner had those, and so we're kind of being triggered by a similar situation. The best thing is to seek your supervisor's support if you're no longer in supervision, to get consultation from someone, a peer, a colleague, someone that works in this field, to help you out and process and sort through that. In some cases, you may have to transfer the client out if you feel like I need some time and I don't want the client sort of waiting around for me to be ready. You can definitely refer out if you need to, because you're not going to be able to do your best work with the client in that situation or those circumstances. So the final area is gender. So I've heard the term toxic masculinity before. What exactly does that mean? Would that basically describe all that falls under traditional male sexuality and hegemonic masculinity? So hegemonic masculinities and toxic masculinities are roughly the same concept. And so to define them, hegemonic masculinity is defined as a practice that legitimizes men's dominant position in society. So when we look at a gender hierarchy, they have a higher position, and justifies the subordination of the common male population and women. And other marginalized ways of being a man. So if you're not like the manly man, you somehow fall beneath that highest level in the hierarchy. Toxic masculinity is thus defined by adherence to traditional male gender roles that consequently stigmatize and limit the emotions boys and men can comfortably express while statusizing other emotions such as anger. And so toxic masculinity doesn't necessarily talk about the hierarchy that's present in gender in our society. it talks more about limiting men to certain behaviors and emotional ranges that end up actually restricting and harming men over the long run, boys and men. And focuses them towards some of the unhealthy expressions of emotions, like everything needs to be expressed through anger and violence. And so there's a little bit of a difference there, but they're definitely connected terms. What is meant by the statement, women do not have to reject all things masculine in order to construct their femininity? How do they show more variability in affectional and sexual attraction across social contexts than do men, and at the same time remain within acceptable norms of sexual behavior, as the author suggests? And so if you think about women in our society, women have been able to transition into masculine or men's roles in a lot of ways over the years. And so, women can wear masculine clothing, quote unquote masculine clothing or gender neutral clothing, and do, work that may not be considered, feminine. Whereas men in our society, if they wear clothing that is considered, feminine, or engage in behaviors or activities or work that's more feminine, they tend to be ostracized, teased, made fun of, bullied, all of that kind of stuff. In addition, when you look at our culture, our sexual culture, in a lot of ways, women engaging in sexual acts with other women has been sort of monopolized. I don't know if that's the right word. In a way for men to experience pleasure. And so sometimes activities between two women are seen as like exciting or okay or whatever, because it brings men pleasure in a certain way, whereas it's less acceptable for men and men to be engaged in those activities together in our society because they see it as being feminized and, not really being a man, and that's not, something that men do and whatever. And so when you look at it from that lens, this statement makes a little bit more sense, that women do not have to reject all things masculine in order to construct their femininity and be able to say, I am feminine, I am a woman. However, with men in our society, you see more that they do have to reject all things feminine in order to construct their masculinity. And so they need to say, like, no pink, no lace, no makeup, no skirts, no whatever, in order to assert their masculinity. And so it's kind of pointing out this, what is it called? Oh gosh, I can't think of the word, but basically when it's okay on one side and not on the other. Like hypocrisy. Double standard. That's the word I'm trying to come up with. There's no evidence that growing up with ambiguous genitalia causes significant psychological issues. I find this very hard to believe. Is the book referring to severe conditions like schizophrenia, depression, or both? So what I'm thinking that the textbook is referring to is that the idea that genitalia alone do not cause the significant psychological issues as much as society's view or judgment of it. So like, if an individual has ambiguous genitalia and, their parents opt to do no surgical treatment and the family normalizes it as the child grows up, and they're in a society, in a world where that's not going to be made fun of or bullied or treated as differently, then there wouldn't be any issues. The problem is that society is what kind of creates the issues, and why people end up, parents will end up having unnecessary surgery to make those corrections when, those individuals are babies or young children, that could, cause issues down the line or in the future. For seeing new clients who may identify as a different gender, what suggestions do you have for starting the conversation on pronouns? So typically, if an individual is non-binary or trans, they will disclose this upon contacting you. So like when clients contact me, they'll send like an email or a text message or a phone call. They'll usually say like, I'm coming in for this, or I have this issue or whatever. If that's not the case, when they're completing your intake paperwork, you want to make sure that you have space on there where it includes gender identity, preferred name and pronouns, things like that. so that they can feel comfortable putting them on there. And then make sure you look at them so that you know what they are. And if they're things that you've never heard of or you're unfamiliar with, you can just kind of say to the client, like, hey, like, I've never heard that term before. Like, how do you define something like that? And, you know, not to take away from the idea that we're supposed to be doing our research, but you can even say to the client, like, you know, I was unfamiliar with the term. I looked it up. I got a definition of it. However, like, I want to just make sure that, you know, what I saw upon looking it up is your reality and is how you see this gender identity or use these pronouns or things like that. And so it's not a bad thing to ask questions and to talk to clients about it. Could a client feel like, oh my gosh, I'm going to be educating my therapist, this is not okay? Maybe it's not a good fit for therapy then. But you want to make sure that it's not that you're putting the onus on them to educate you in general, but allowing them to educate you on themselves and their experiences of it and things like that. Also, it's important to remember that if you make a mistake, you apologize, you correct yourself, and you move on trying to do better. You don't dwell on it, because then that makes it about you and the mistake you made. Apologize, correct yourself, move on, keep trying. There's an activity that I recommend to students to do, and that's where you think about like you think about an experience you had when you were young, like, you know, tell a story about, you know, a childhood friend or, you know, a sibling or a cousin or something that happened or whatever, and then retell the story from the perspective of a different pronoun, a different gender identity. So you can switch he to she to he, you can switch she or he to ze or they, and so on. And so just kind of practice with it and play with it so that you start to get used to doing it. Don't get frustrated with yourself. It's not the way that maybe, you know, we're used to, you know, being raised in school and whatever, learning he, she, they, and those differences. It's something new and a little bit different. And so just practice. It's the only way you're going to get better at it. What happens if the counselor fails to ascertain that an individual meets the criteria for gender dysphoria? Does this solely depend on the therapist's judgment? Is this still a requirement? So gender dysphoria is a diagnosis based on criteria in the DSM-5, and so the client would have to meet the criteria necessary. A diagnosis of gender dysphoria is required by medical providers to prescribe hormonal and surgical treatments for gender affirmation. If you look in the past standards, it says that, and I forget exactly how it's worded, but basically not all medical providers require a letter for hormonal treatment. Some still do, even though it's like they don't have to. It's just like an extra safety precaution. So you might find some providers that provide hormonal treatment without a therapist letter and diagnosis. Not all clients who have gender dysphoria will desire hormonal treatments or surgical treatments. They may just decide that that's who they are and that's how they want their appearance to be and their behaviors and the pronouns and all of that kind of stuff, but not actually take any other measures. And some might. And so just because someone has a diagnosis of that doesn't mean that you need to end up doing letters for them or they're going to go through any of that. If the client does desire those treatments, so they have to have that diagnosis for those treatments and they need a letter written, you will need to complete a formal assessment to assess the need for any other treatments on any other comorbid mental health disorders or issues. You'll have to give the client or refer them to services for that. This is similar to letters that clients will ask for like gastric bypass surgery and things like that. So you have to work on their any other mental health issues and make sure that those things are stabilized before the client gets the medical treatment. And so again, this is outlined in WPATH Standards of Care. The book mentions that, I apologize for my yawning. It's so hard when I'm by myself with just a computer. The book mentions that counselors should be aware of much of the distress trans individuals experience is due to social discrimination towards their sense of self. I wonder how many non-Black counselors are able to understand that this is the case for a lot of Black people. It's just more complex because you can't change the color of your skin the way in a way that you might with your dress or your hairstyle and things like that. And so I really appreciate you bringing up this point. This same or similar level of distress can be present with many individuals who identify across any and all marginalized communities. And so this is why we as counselors are called to be advocates for the greater community. And that's why ACA has included it in our standards. This is why KCREP has included it in what part of our education needs to be. We need to be working for the greater good. We need to be checking our biases. We need to be self-aware of how our biases may be playing out in, the form of microaggressions or even macroaggressions against clients or in the general community. And so it is so important for us to be aware of this, and it is so important for us to work on that. And so I do appreciate that question being asked and being brought up, because, I really don't think I can state that emphatically enough that this is something that we need to work on. I heard or read cases in which children as early as 3 years old are taking puberty blockers. I know this is my bias, but I believe that children are not mature enough to determine that they are trans. Is it possible that parents may be leading their children to think they are trans? Are there specific behaviors that determine that children may be trans? Is there research that demonstrates positive effects of puberty blockers in children as early prevention for mental illness? Are the blockers reversible? So first, there are different standards, criteria in the DSM when you look at gender dysphoria for children and adolescents versus adults, and also in WPATH standards. So that is one important distinction to make, is that there are different standards for children than adults. Looking at puberty blockers, they are used specifically for this purpose, to prevent puberty from coming on. And so with that, it's fully reversible. If an individual stops taking the puberty blockers, then the natural puberty process begins to occur. For those who are able to recognize this level of extreme dysphoria in themselves with their gender, this can help those young people prevent the trauma of those secondary sex characteristics and going into puberty in a gender that was assigned to them that is distressing to them. And so it can be something that can be helpful to use, and then as the individual reaches the age of 18 and gets a little older, they can start making decisions about if they want to take some of the other treatments like hormones and surgical treatments. And so I did not watch a lot of the show, and so I cannot speak fully about it, but the media individual, Jazz Jennings, which I know that's a pseudonym, but she is one of these individuals, is that the gender dysphoria was very obvious, that at a certain point she was becoming so distressed by her body and people categorizing her as a boy and a male, that her parents ended up making the decision for her to take puberty blockers. And so she ended up being, continuing to be raised as, a female, and adjusted in a much better way, and ended up becoming an advocate for the community. And when she was approaching the age of 18, she began to think about and discuss the use of hormones and potential surgical treatments and things like that. And so I think at this point, I don't know how old she is now, but I believe that she has had, a number of surgical treatments so that she can feel more comfortable in her body and it match her true gender identity. And so that's a situation where this might take place. Let me make sure that I got everything. It can help the affirmation process sometimes be a bit smoother because you didn't have to go through the puberty of a gender that didn't fit for you. Again, the WPATH standards outline clear criteria for interventions to take place. Is it possible that some parents might be pushing a little too hard? Like, oh, I see these things, they must be trans. I mean, possibly. I mean, there are some kids who, just like to play with toys that are both, identified as girl and boy toys, who like to engage in girl and boy activities and whatever. And so I think that it is a society issue of us forcing this choice, having gender reveal parties and having aisles in the toy store that are girls versus boys, having products in pink or blue. And I think that the more we move away from that, the easier it will be. And the less people will have to be like, oh, is my child a boy or a girl? Or, what's their gender identity? It's like, just let it happen. We don't have to push it. Is there a specific reason that insurance companies do not deem it necessary to cover top or bottom surgery, even though it is evident that it's causing mental distress? So there's still a lot of controversy about these procedures being medically necessary. And so this leads an individual insurance company to determine whether or not they will cover any treatments, including hormones. And so it is very individual. Most insurance companies don't cover a lot of these things. Some will. Or some will cover some. It's the same way with infertility treatments. They're often not covered. Very few insurance companies will cover them, and the ones that are covered are the much lower ones and not the ones that, are at a little bit of a higher cost and a little bit more invasive when things become very difficult. There is advocacy work for this cause. It's important for us to advocate for our clients so that their insurance will begin to cover these treatments. Is there a reason why some individuals prefer to cross-dress and others prefer to go through gender reassignment surgery? So cross-dressing and being transgender are two different things. There's some individuals who simply enjoy dressing in clothing of the opposite gender at times, in shows, day to day, maybe in private, whatever. And there are also those individuals who gain sexual pleasure through certain clothing of the opposite gender, which would be transvestic disorder, which we're going to be learning about a little bit more detail in a few weeks. And then there are individuals who are transgender, many of whom feel that they have a level of dysphoria associated with their gender assigned at birth and want to take steps towards some kind of affirmation treatment. So it could be completely like changing their name and their gender markers and potentially hormonal and surgical treatments. Not all trans individuals take all of these steps. They may feel comfortable living life in their identified gender without the need of those, and so on. But just making sure that you know that these are kind of different things. These words mean different things. This is about starting hormonal treatment, evaluations required. To refer to an endocrinologist, the evaluation is to assert certain that an individual meets the criteria, that their distress is not better explained by another mental health diagnosis, and that they're familiar with the medical benefits and risks of hormone treatment. What are some examples of a client's disposition being similar enough to gender dysphoria, but actually the cause of another diagnosis? Imagining that if a convict recently is released struggling with gender expression after being subjected to the feminine role in a penitentiary. But I'm also imagining that a client with gender dysphoria will provide very clear signs, keep it from being confused for another. And so in a lot of ways, you're going to see these gender issues from a very young age. And so someone in a situation like you discussed with being, in a prison and whatever, and having some confusion, it's most likely a result of that versus something that is like actually gender dysphoria because they may not have had those signs from a very early age. In some cases maybe they did and they didn't recognize it or didn't try to hide it or push it down or whatever, and then when this experience happens in jail, they kind of feel more in touch with it. And so there are lots of different individualizations with this. And that's one of the things that an evaluation does when a therapist does an evaluation with an individual is look at the history of these things. These individuals, when they go through puberty, especially in the secondary sex characteristics start to develop, they have a lot of difficulty with that. You also want to make sure that there's no comorbid mental health disorders that are causing issues. And so, for example, depression symptoms could be related to living in a society as a gender identity that doesn't fit, or it could be depression that gender affirmation treatment will not improve and therefore needs to be addressed with counseling and potentially medication first. Another example is an individual who develops an eating disorder. It could be related to the gender dysphoria, in that, they didn't want to have a lot of body fat because they didn't want to have, breasts develop in a curvier figure, or gaining a lot of weight so that they could have that. And so those things would need to be addressed and taken care of first, because they may not actually be related to the gender dysphoria. It may just be that the person has an eating disorder for other reasons that need to be addressed separately. If a client is discussing and contemplating undergoing gender reassignment surgery, should we be in contact with the surgeon, the team of doctors, especially things that can drastically alter the client's mood and feelings? Yes, clients should sign a consent form so that we can be in communication. In some cases, the client may come solely for the letter to begin treatment, so we might not see them again. I always let them know that they can come back, because I give them information about all of the things that could occur after they start taking the hormones or after surgery, and let them know that it might be a good idea to come back into therapy if they feel some of those things happening. You also work on finding them support networks, support groups, and other providers. And so it's possible that they might get some of the support with those changes from these other resources that you connect them with. Next question, though, counselors might familiarize themselves with the WPATH standards and algebraics competencies. How can they meet the clients where they are in terms of understanding their identity? Many underserved communities are not exposed to safe spaces to explore their gender or sexuality. Do we have a role to play in psychoeducating clients in terms of potential definitions and psychological conditions? Yes, absolutely. One of the parts of completing the assessment, specifically for trans individuals for writing letters, is discussing and doing all of that psychoeducation, helping them to understand their options and research them and think about them and consider them. Sometimes clients will already be fully invested and involved in the community when they come to you for different things. Others will just kind of be beginning the process. And so it definitely depends on where they are in their world and their process. But we may be in a position to have to connect a lot of these things for them. The counselor's role in working with trans clients is described as working with case manager and consult in addition to counselor, which is some of what I just mentioned. That the text mentions assisting trans individuals going out in public for the first time dressed as the transitioning sex and connecting these clients with medical professionals that are accepting of their situation. I also know that knowing places in their community that are trans friendly. It seems like a lot of out of the office work. Do therapists that work with this community typically work only with this clientele or other concerns? It depends. There are some that only work in the trans community. There are some that work with just the LGBTQ plus community, and there are some that work with the community and outside of the community. So this definitely varies. And the counselor's ability and willingness to go outside of the session it just depends on you and your philosophy of counseling and how you work with clients. In many cases, insurance may not cover some of the things because they cover your location and not, if you're out walking around or in other places with the client. You may also feel that there's part of you that might be breaking confidentiality if you're out in public with your client. So these are all factors to consider. Usually I work with the client in identifying individuals in their life that can help them and support them through this process, rather than me being the one to do it, so that it's very transferable, because those are going to be people that are going to be in their life every day. I think I covered everything. How do you best help an individual who's struggling with gender identity but has strong religious beliefs? Again, it's a big challenge. It's about exploring their identities and their beliefs and kind of sifting through them. Where do these beliefs come from? Do I truly believe that? How do I feel about sort of denying my gender identity? How do I feel about kind of shifting and adjusting my religious beliefs? And so sometimes it may come down to that choice. Gender identity, at least from my view and the view of the counseling world, is that this is something that can't change. You can't just say like, oh, I feel like I'm truly a woman, and then all of a sudden just be like, okay, my religion's against that. I feel like a man. It's not a choice in that way. Whereas religious values and beliefs, we do get to choose what we believe in. And in some cases, it's like, if I truly believe in my religion, then I believe that X is truth. So like for me, I'm a Christian. I believe God is truth. Jesus is truth. There's not a lot of choice in that. But I can also decide how I interpret their works. And so do I interpret the Bible by saying there are things in here that are anti gay and anti-trans, and that I believe those things, and so I don't believe in, people having these identities? Or do I say that there are parts of the Bible that say we should love one another, and God and Jesus commanded us to love one another, and do I believe those parts of it? And so the individual doesn't totally have to change their religious views or beliefs in order to feel a sense of congruency in those two identities. However, if they do feel very strongly about those beliefs and values, then this one is a little bit more of a struggle, a little bit more of a challenge, and you just kind of do the best you can to help the client sort through that, make sense of it, reconcile with it, and so on. Recently, a coworker told me about a specific situation when she was going through with her partner's sibling. My coworker and her partner are pregnant. Her partner's sibling considers themselves gender fluid. During the baby shower, they were getting angry. So the partner's sibling was getting angry about being called an uncle because they don't identify as male. My question is, with the English language lacking a gender neutral word, so like instead of aunt or uncle, which are gendered language, we don't currently have something that's gender neutral. What's the best way to handle this situation when there's no word that can be appropriate for that individual, and you don't want to insult or offend them? My go-to is always ask questions. And so, as the sibling, I might say to them, like, okay, so I'm having a baby now. Like, obviously, this is your gender identity. And we don't really have a word for uncle and aunt that fits. What do you prefer to be called? Do we make up a name? Do we whatever? And let that person feel free to explore what they feel comfortable with themselves, and then adhere to that, and then let other people know about that. Like, somebody's like, oh, how's the baby's uncle doing? Well, this is actually not the baby's uncle. This is the baby's whatever. And that's how they're going to identify, or the child's going to identify them. And so I think it's a lot more confusing for us adults than the kids. I think the kids will be fine with whatever terminology we give them. I think it's important for us to work on being flexible with ours. And that's about it that I have for that. And that is it for the questions. I hope that you got a lot out of this video, this document, and this chapter. And you'll be seeing me again when we talk about the OQEs for Chapter 8. Thank you.